After the first meeting, Arnie Milstein told me he'd buy me dinner if this program ever got off the ground. And Arnie, you still owe me that dinner.
If I remember correctly, what happened is Mark Smith, on behalf of California Healthcare Foundation, stepped forward. Steve Shortell, who was regarded as a sort of a respected neutral, was brought in with funding from the California Healthcare Foundation to begin to work with the plan leaders and the medical groups. And if I remember correctly, I think it was Bud Volberding from Cigna, who was the first person to kind of not only say we need to do this, but to link it to what was ethically right to do from a societal perspective. And I think the combination of one plan, anchoring a decision around what is fundamentally an ethical decision, combined with kind of a respected neutral leader like Steve Shortell, and then aided massively by the connections and the persistence of Steve McDermott with I remember he had at least one other partner in that process, and they made it happen in an environment in which I think anyone would have bet against it, including me.
In 2000, as chair of the IHA Board of Directors, I took on Pay for Performance as a 2-year effort. Initially, health plans were supportive, medical groups not so much. They were skeptical and distrustful based on their relationships at the time.
I played a role in trying to help convene the parties, that is, particularly the health plans and the medical groups and hospitals under the leadership of IHA, to try to solve this problem that we had, which is principally that all of the health plans were talking about physicians doing a better job of reporting on and improving the care of their patients, but each of them seemed to have slightly different metrics, slightly different approaches, and everybody was scared to death about the antitrust implications of plans getting together and then approaching physicians and medical groups. One of the roles that the foundation can play is as a kind of an honest broker in bringing together the various partners who needed to come together to make P4P a reality.
As I tried at critical moments when one party or the other or both parties would lose energy or want to give up or say, look, let's just go our own way, this kind of group solution across plans and across medical groups is just too difficult. I think what I tried to do is keep the eye on the prize.
NCQA has been the measurement partner for the California P4P program, and we've been very proud of our work in adapting HEDIS measures and in coming up with measures of systems capabilities. We've worked very closely with the great group. It really has informed our ability to do these kinds of local projects around the country. And it's also made us much smarter about future directions, I think, for federal health policy.
The improvements in quality have been incremental, not breakthrough, as some would have hoped, but that surprises me not when you think of a state the size of California, probably 12% of the population of the nation, a highly diverse state in geography and in the socioeconomic makeup of its citizens. So incremental improvement is just fine, provided that the trend line continues to move up, which it has been doing, continues to do. So I hope that we all work together to preserve and build this program because it will continue to be a pillar underneath accountable care, which is a goal we all seek.
This kind of work is so important that it makes you realize how much nicer it would be if we had these kinds of measures available for a broader range of areas of performance, and in particular, more outcome measures, more measures related to total cost of care, more measures that could really help us focus on what we want our healthcare system to do, and that's deliver the best care and the best population outcomes at the lowest cost. We still have a lot of work to go in that regard, but I'm hopeful that IHA and the efforts of this Pay for Performance program can continue to lead the way.
Everybody was in a different spot, I think, on the change continuum, and we certainly had doctors who, once we gave them good data, they were able to move things along quickly by themselves or with some small assistance, and other doctors, who are not only difficult to engage, but frankly, actively resistant. And we had several cases where initial resistance was met with, gentle re-education and encouragement. And one case in particular of a doc, a primary care doctor in one of our regions, who was very vocal and very resistant, but sort of was willing to look at her list of patients and made some outreaches. And at a follow-up meeting, probably 6 months later, was somebody to stand up at the meeting and say, and admit that she had been resistant about this and thought, listen, I was too busy, I'm not sure if I trust the data, et cetera. But long story short, ended up doing some screening interventions on a patient she otherwise wouldn't have if it wasn't motivated by pay for performance, and discovered an early-stage breast cancer on a patient who she had sort of written off that wasn't going to do this, and instead she said, "You know what? I'm going to try one more time," and that was true. That was a huge game changer for her, but also among the primary care docs to hear that kind of story. I think from a peer-to-peer standpoint, was created a lot of movement for us.
For me, the biggest achievement of the California Pay for Performance program has been the demonstration that you can take a large number of medical groups at varying levels of development and collect quality information and even build internal capabilities, because I think that's one of the great outcomes of the project. And you can have an orderly attempt to reward quality in a way that it really never has been rewarded before in the past.
One of the big achievements from our perspective, the things that it's helped motivate internally at the medical group, really has been this engagement of doctors back with data. I mean, physicians fundamentally enjoy interacting with data, but they have to kick it and sniff it and trust it. And we've been able to get good data to docs and give them real feedback about where things are under-optimized and where they're doing quite well. And they actually like having conversations that are data-driven.
I know from our own efforts in other states and nationally to get to consistent performance measurement that this is not an easy task. Bringing together a broad range of health plans, stakeholders, physician groups, all behind a consistent effort at performance measurement is something that is a really tremendous achievement. I think that's the most important, one of the most important things that the program has accomplished, is showing everyone that it is feasible to get all of the plans, all the providers, all the stakeholders on the same page and actually get good performance information out.
The biggest disappointment is it has not yet solved the problem of how we should be paying. Has it had as big an impact as we might like? It clearly has not. And I think most of us think the proportion of physician income that comes from this kind of approach is still probably inadequate to transform the delivery system.
We still overplay quality, so I'm still disappointed in that, and we underplay the performance as a broader concept. But I think that the fact that we measure patient satisfaction is a big improvement, and the fact that Pay for Performance has really promoted IT development among the medical groups is a big success as well.
I think the biggest achievement for the Pay for Performance program is really that it's so strengthened the California delivery model, our delegated model, our presently existing system of accountable care, such that we are really the hallmark of the policy direction that Congress has placed the nation on, the path it's placed the nation on. And so the other 49 states are all looking to California for guidance on how to adopt and implement accountable care, bundled payment systems. And
the Pay for Performance succeeded in getting the plans working together. We now all accept the idea of measurement and public reporting, and 10 years later we take that for granted, but at the time, in 2000, that was pretty much a wild idea.
I think the whole country has learned from their experience with this, and it has been a wonderful opportunity also for NCQA to support the work as a measurement partner. And I think, the federal government and in healthcare reform is really looking to build off some of the lessons that the IHA Pay for Performance project has taught us.
I think the program has had a really important influence, not just in California, but across the country. It's been a model for how to get to consistent performance measures that enable consumers and physicians to make a broad range of comparisons across many different groups and many different health plans. It's the kind of model that we need to be adopting much more widely.
And I think all of this rolls up into essentially the clinical data engine from a monitoring and improvement and accountability standpoint of the accountable care organization. These are the tools we need, and I think what the Pay for Performance program under IHA has done has been to get us all up to that, to have that engine that really is the key driver of a successful accountable care organization. And my hope, frankly, is that in doing all of this retooling, that we also are going to be left with an improvement in experience of care from those of us who are part of the delivery system.
We think that the Pay for Performance program has helped position California organizations for the future very well. As we look forward to the future for Pay for Performance, certainly we would hope that it is adequately funded, and that is important to build and maintain a robust program, one that pays, bonus and incentive compensation out for the performance of this good work we want done, sufficient really to create ROI, a return on investment, because the development of the infrastructure of performance measurement and management is expensive. It's worthwhile. We all applaud it. We want it, but it costs money, and that investment, those capital investments, really need to generate a return.
Value-based pay for performance is intended to address the cost and should be a game changer. We need to rebuild the shared risk incentive that we abandoned in the late 90s, and do so this time with all oars rowing together to have a meaningful statewide impact.
Does the move to value-based P4P seem directionally correct? It does. I think it's the right thing to do to say it's not enough for us to get better. We gotta get cheaper as well. So if the definition of value is we're going to get better and cheaper, great. So I hope that the term value doesn't become a way of kind of weaseling out of the hard reality that we've got to find a way to make healthcare do just as good a job or even better job at less money than we're spending on it now.
I think the increasing emphasis on value, that is how do you get the best possible outcomes without unnecessary cost, fits right in with what our healthcare system most needs today. The emphasis on the new total cost of care measures should be an important step in this regard.
Congratulations to all the medical groups who have stepped up over the past 10 years. Not just the top performers, but all the groups who've raised the bar across the board and across the state.
The Pay for Performance program creates what I like to think of as the second of the two pillars that really support accountable care, the one being population-based payment and the other being a performance program, Pay for Performance, that includes quality and other measures. And the two work together in harmony to develop really an accountable care system.
My closing thoughts are keep up the good work, and we love working with you, and you really have changed the conversation. You've informed the conversation about costs and quality in healthcare in a way that nobody else can point to, and you should be very proud of what you've done.
I would, even though Steve has been generous enough not to collect on his vet, it would be happily paid by me, given what has subsequently transpired.